Welcome all to the special edition of the TB Think Tank webinar series. This session is titled Updates to the Diagnostic Targeted Product Profile for TB Detection, presented by Prof Mikashmi Kohli. A brief introduction of today's presenter. Mikashmi Kohli completed her PhD in molecular medicine from the All India Institute of Medical Sciences and did her postdoctoral fellowship at McGill University. She has been working in the field of public health for over 10 years now and has extensive training in evidence-based medicine. She has served on 7 WHO Guideline Development Group meetings, developing global policy on diagnostics, where she has supported evidence synthesis on new diagnostic tools using the GRADE process. She is on the expert committee for the first pre-qualification for TB in vitro diagnostic tools, as well as supporting the technical specification series for computer-assisted detection for TB. Prof has led several projects related to accuracy of molecular TB diagnostics and also to assess availability and accessibility of diagnostics in primary healthcare settings in low and middle income countries. She is passionate about evidence-driven policies and implementation strategies for diagnostics in global health. She has served on the Lancet Commission on Diagnostics, where her work on cascade of care for different diseases and cost modeling was key in summarizing the Commission recommendations. Over to you, Prof.
Hello, everyone. Thanks for the very kind introduction. So I'll be talking about updating the diagnostic TPPs for TB detection. And I'm just going to quickly try and share my screen. See if we can get this in the presentation mode. Can you confirm that you're seeing this in the presentation mode? Perfect. Great. So we'll be talking about target product profiles for TB and how did we go about updating them. So starting off with what these documents are, when we say target product profiles, and I'll be speaking from the perspective of the WHO because that's what we ended up doing. Now, WHO target product profiles, their main purpose is that they need to support the development of missing health products. I'll be talking about the tools-related TPPs, but there are TPPs for drugs, for vaccines, etc. And they help put together a document which is more of a guidance document for manufacturers, for regulators to really understand what is the need and what is a public health priority to get a product out in the market. And it needs to recognize, the TPP document itself needs to recognize that access, equity, and affordability are an integral part of the innovation process itself. So, and these three factors about access, equity, and affordability needs to be considered at all stages of an innovation, whether you're designing or whether you're implementing or really assessing the product works or not. And then, as I said, that it is a strategic reference and planning document, which many people use to look at this document to understand what kind of products are really needed in the market, what kind of products should I be developing. So this is a very manufacturer specific document, but it's not just for manufacturers that they are the big piece of the population that look at this document, but it is an important document for policymakers, for implementers, etc. as well. Now, because it is a strategic and a reference document that is needed for any product, it has many parameters that really go into it, like what is the use of this TPP? what is the target population that the product should cater to, and what are the desired attributes, and how can it guide the product development process. And I'll talk about each of these parameters in a while, but this is more of an overarching view of what these documents really do. Now, in 2014, we developed these target product profiles for TB. And when we were listing out what the priorities are for TB tools, we listed out these priorities. So there should be a triage test. And when we talk about triage test, we were thinking that it should be for somebody who's seeking care. This test can be used in HIV ART clinics. It can be used in the community because that is where we do most of the systematic screening. And then there should be a test for rapid diagnostic TB diagnosis with an optional DST testing as well. And even within the TB diagnostic testing, we had different categories. One was a sputum-based cartridge test. There could be a biomarker-based test. It could be a multiplexing test. And then there was a next-generation DST, treatment monitoring test, and predictive test for latent TB infection. So this is how we really prioritized how we should be looking at TB tools. Now, the first two here, this is what we updated in last year in 2023. This one for next generation DST, it was updated in 2021. And the treatment monitoring one, which was the first time that we ever did this TPP, it just came out last year as well. And for latent TB infection, predicting as a predictive test, it was published in 2017. There is a lot that is happening in this space as well, but we haven't updated it since 2017 yet. So when I say that there is a TPP update, and that's the topic of the webinar as well, but why did we need an update? Why could not we just be okay with what was published in 2017? So one of the reasons was that there has been a surge in new technologies. Most of you would know that the pipeline is very rich and the innovation in this space is increasing exponentially. And TPPs are something that is not a retrospective fit. It is something that is more forward-looking to look at what innovations we should look forward to, what innovation manufacturers should think about for public health impact. And when we talk about the surge in new technologies, if you would see that this is where we were in 2010. So we had Expert MTP RIF, which was labeled as the game changer for TB diagnostics. But since then, there has been a lot of new technologies that have come up, which is line probe assays, TB LAM, even different versions of Expert MTB. And then there have been centralized tests like by Roche, by BD Max, Abbott, etc. South Africa is a really good example that has been using centralized testing for TB, and also not using AI-based tools, machine learning as well. So we see that this pipeline is just getting richer and richer, which calls for more and more guidance on what we really think would make a public health impact. Even for TB LAM, we currently have one test, the Alair LAM, but the pipeline is increasing because there are many more candidates that we are looking at currently, which are now labeled as next generation LAM. And again, all these technologies, whether we currently work with sputum-based testing, but there are so many technologies that are going off sputum-based. So whether it's face masks, whether it is acoustics, or tongue swabs, all of these innovations really exist, and we really need to see how to guide manufacturers in getting these innovations out. Similarly, for chest X-rays, when we started working on chest X-rays, the computer-assisted detection, we just had 3 software. But now there are over 22 software that we are looking at, and we will be evaluating them very soon with the WHO to understand how these new technologies work. Similarly, There are AI-based point-of-care ultrasound machines, digital stethoscopes. There are cough apps. People are currently evaluating them. And this is where we are moving in terms of new upcoming tools. So when I say obviously we currently have a lot of these technologies, we really need to understand how to get them out in the market and if they are really worth getting them out, if it's really worth getting them out in the market. So what we had in 2014, we went back and looked at it. So this was a 2014 document which was published in April, and we had these three different TPPs. One was a biomarker-based non-sputum-based test for diagnosing TB. There was a community-based triage test, and there was a rapid sputum-based test for detecting TB at the microscopy level. So these were the three TPPs that we had in 2014. And as the technology space improved, but also the lifeline of a usual TPP is 5 years. So we really wanted to see in these 5 years what has changed and do we need to update. So we did need to update. And one of the other, the third reason was that we wanted to make this a leaner document because we heard the feedback from manufacturers, from regulators to understand how they view these TPP documents, which were published in 2014. And we got a lot of feedback that sometimes it's confusing. They put out a product to evaluate, but they really don't know where their product is fitting in these three TPPs. It was a bit confusing. So then we decided and we proposed that we are going to make it a leaner document and look at these two scenarios. One is a screening TPP and second is a diagnostic TPP. So this is what we proposed for to the WHO for updating these 2014 TPPs. For screening, we said this is a use case that we know. We need a test that can help identify people who are presumed to have TB and they need further diagnostic evaluation. And second was a diagnostic TPP. The overarching goal or the scope of this document should be that manufacturers should look at developing a test that can detect pulmonary TB, but also optimally extrapulmonary TB, either using sputum-based tests or non-sputum-based specimens. And most importantly, you get a test out, but if you put a fancy innovation out that is providing results after 2 or 3 days and there is no feedback mechanism to really put the person on treatment, then we are losing people in the care cascade, which is the problem that we currently face. So we really wanted to work on this diagnostic TPP where people can be put on TB treatment in the same clinical encounter or on the same day in peripheral settings. So that was the healthcare tier that we were focusing on. For the purpose of this webinar, these were the two TPPs that we have worked and we have updated currently, but I'll be speaking mostly on the diagnostic TPP. So thinking in terms of the layout of this document, what does it really look like? Now, as I was saying that it is a product-based specific document. We look at different parameters. What are the parameters that are important? What is it that the manufacturers will be looking at when they're developing a test? So these parameters are binned into different sections. So first is the scope of the use, or scope for use. What is the goal of the test? Is it a screening test? Is it a diagnostic test? Is it a treatment monitoring test? What is the population that I want to focus? Where will I really place this test? And that is where the target user comes into place. Pricing, our favorite topic. What is it that would be a price per test? The capital cost is if it's an instrument heavy test, what are the capital costs that manufacturers should try to aim at? Performance characteristics, obviously, what is the sensitivity, specificity that the manufacturers should focus on achieving? And also operational characteristics. So power supply, does it need electricity? Is it battery operated? What is the usual throughput? Does it have digital connectivity, etc. or not? So all of these parameters And this is not an exhaustive list. So based on the use case of the document, and what are the important characteristics, important parameters, this list can go further, can actually be increased, or we can delete some of the parameters as well from this list. Now, for each of these parameters, we have a minimal characteristic and an optimal characteristic. What I mean by minimal characteristic is that it refers to the lowest acceptable output for that characteristic. So what is it that is realistic, but it is also something that the manufacturers really need to achieve for a specific parameter. And then an optimal really means that it is the ideal output. So for optimal, we want to push the manufacturers to go that extra mile in terms of innovation, but still trying to be within the realistic realm of achieving that target. So for each of these parameters that I mentioned, there will be a minimal and there'll be an optimal for each of these parameters. Now, thinking through how does it work? What do we really do when we say that we were updating? So this is what the workflow is usually. There is a draft 0 for the TPP, which is done by the core team, which could consist of 2 or 3 people, which will do the drafting, the draft 0 for TPP, keeping all these parameters that I mentioned, and for each parameter, drafting the minimal and the optimal. Now that draft is shared with the writing committee, and the writing committee is also a smaller group that would consist of about 7 to 8 people who really have either previous experience of writing a TPP, but also has experience in the specific or are subject matter experts basically. But we do not have manufacturers in this process, and I'll tell you where manufacturers come in. And especially in a process that is led by the WHO. We do not have manufacturers as part of the writing committee, but the draft, when it is shared with the writing committee, that we get the comments back, we revise that TPP based on the comments. And then there is a TPP development group, and this was commissioned by the WHO. We had about 65 people in this TPP development group this time. And this revised TPP is presented to them in form of a webinar. And then post that webinar, there's a Delphi process that is started where each of these 65 members of the development group gets to rank each of these parameters. And I'll show you what that really looks like. Post the Delphi process, we look at what were the consensus on each of these parameters. We look at the comments. If people provide comments on these parameters, we revise it, and then we put it out in the public domain. So when I say it is put it out, it is out there in the public domain. It is usually done on a WHO webpage. And we also obviously used our LinkedIn profiles, our Twitter profiles to spread out the word that there is a public comment open for a specific TPP. The reason is that we do want everybody to be able to comment on that document, to gather as many comments and as many perspectives as possible. And it is at this public comment stage where we invite the manufacturers also to really comment on that document. Then it goes through a public comment. We analyze the results. And the final consultation happens again with the TPP development group, and there are revised documents that are available. Just in terms of timelines for the diagnostic TPPs, this is what the timelines really look like. And when I say TPP development group, as I said, there were about 65 people in this group. These are experts in the field of TB. There is country representativeness. There are usually national TB program managers from most of the countries that are present around the table. There are online consultations that are done, and also a Delphi-like survey. Now, coming to the parameters, as I said, there is a draft 0 that is prepared. But how do we really define, how do we write down these minimal and optimal characteristics? So some of these parameters evidence, or we kind of know what the scope is, right? That is why we will start a TPP if we know what the scope looks like. Now, once we have the scope, sometimes we also know if it's at a primary healthcare level, do I need a battery operated instrument, or do I need instrument-free test if it's a community setting? So some of it we know, and that is why we have these experts in the field who help us guide through these texts. But what about sensitivity specificity? What about pricing? Especially for sensitivity specificity, now the ideal would be having 100% sensitivity, 100% specificity, but we all know that is just not possible. There is no such perfect test that exists. But let's say I can put a 99% sensitivity and a 99% specificity. It would be good to have that. But again, is it realistic? Is it possible to get that? Not quite sure. So when we did this in 2014, we went ahead with what we knew we have, what is coming up in the pipeline. And that is how we worked around the consultations. We thought what would make most sense for public health impact, and we wrote those estimates that are in the 2014 TPPs. But this time, we decided we need more evidence-based estimates. And this is where we started working on some modeling estimates. So our main question was, can we look at some modeling estimates which can help us guide in a more evidence-based decision-making process on what is the acceptable trade-off between diagnostic accuracy, cost, and access to testing. So we did this modeling exercise in 3 base countries. As for all models, we need a base estimate to really understand and answer the. We worked with data from South Africa, India, and Kenya. And what was the research question for this modeling? What is it that we were trying to solve for? It was basically this. So let's look at this left box here. This is the gray box, the big box is the entire population. And let's assume there's a test A that is easily accessible to people just because of how the test is. It's easy to do, it's battery operated or a strip-based test. And the total access of that test is about 75%. But that test has a very lower accuracy, where it can only correctly diagnose 64.5% of the people. It has a high false negative rate, where it is about 35%, and a 0.5% false positive. Whereas on the other hand, if in the same population, a test that is able to correctly diagnose 84.9% has a lower false negative rate, has a lower false positive proportion. However, that test B is only able to reach 25% of the entire population. When looking at this test A and test B, even though with a lower accuracy in test A, that test was, because it was reaching far more people, it was able to diagnose 48.5% of the entire population correctly, whereas test B, with a higher performance, however, low accessibility, it was able to correctly diagnose 21% only. So this is what we were trying to understand. What is that acceptable trade-off between easy access or higher access and accuracy? If I'm able to reach more people, how low is it acceptable to go on my accuracy estimates? And this is what we were trying to solve for. Now, when I say access, that can have many different meanings. So we tried to build consensus on how can we define access. This is how we tried defining access in terms of different healthcare level and different kinds of technologies. So you will see in the published updated document that we have a point of care test, a near point of care, and a low complexity. And this is how we try to differentiate between these three. One, does it need an equipment, what kind of infrastructure is needed, and what kind of human resource skill set is needed in running these three. So obviously, the access to a point of care test, which really does not require an equipment, does not need any infrastructure. Anybody, even potentially could be a self-test, can do this test. It obviously would be more accessible as compared to a low complexity, more expert-like test that needs infrastructure, that needs certain skill set to perform this test. So this is how we try to define the access parameter in our model. Now, as I'd mentioned that we did all this work and we presented it to the TPP development group for each of these parameters, not just the modeling, but obviously modeling was a core part to understand the evidence-based synthesis of this accuracy estimate. So I just wanted to share how each of these parameters look like in the Delphi results and how much work it went into even for the TPP development group to comment on. So this is just a snapshot of the Delphi results. So each of these parameters, and there were over 85 parameters, because what is the target population? That had a minimal, that had an optimal. The target user had a minimal and an optimal. So each of these were different parameters and characteristics that people commented on. And we looked at the percentage agreement. So on a 5-point Likert scale, we looked how many of them actually agreed with what was stated in the document. So our threshold was 75% agreement or above, and all these reds were below the threshold. So we looked at all these that did not reach the consensus or the agreement, but we also looked at each of the comments. So if people provided comments on even the ones with 91% or 93% agreement, but if they were valid comments, we went through them, we made certain changes, and post this Delphi result, the TPP was revised based on the comments that were provided by the development group, and then we put out the revised document on the public domain. Now, in this public domain, the document was out there for a month. People commented on it. And there were over 362 people who actually commented on all these parameters. However, as a WHO policy, we need consent, signing a conflict of interest form, etc. And only 57% agreed and consented to that. So we could only use results from these 205 people. And on the graph here on the right basically shows the different stakeholder groups. So we had a lot of people from the industry, as expected, providing comments. We also had people from academia, research groups, from NRLs, SRLs, UN agencies, implementation partners across the globe who provided comments on this document. Even in terms of geographical representation, as expected, we did have a lot of representation from high-income countries, from the US, but also these light and dark shading of purple, we had a lot of low middle-income countries as well comment on it. So I've spoken about what it looked like, what was the process, why we did it, how we did it briefly. I just want to dive down a little bit into what the final text looked like after all of this work. So this is how the document looks like. I mean, the document is bigger, but I just wanted to hone in on providing some context. So when we say that there was under scope, what is the goal of the TPP document? As a minimal, what we said was that the document should be able to provide characteristics for a diagnostic test for detecting pulmonary TB at a peripheral level so that the person can be put on TB therapy in the same clinical encounter. Now, as I said, as an optimal, we want to push the boundaries a little bit, but still being realistic. In addition to pulmonary TB, we added extrapulmonary TB and a drug resistance testing. So this is what the minimal and the optimal differs in. And there are always nuances around it. There is always more text or explanatory text that we need to write. And that is where this column is really helpful on having an explanatory note column. Similarly, for target population, we started off in the minimal with adults and adolescents. irrespective of HIV status. But as an optimal, we said adults, adolescents, and children presumed to have pulmonary, but also or extrapulmonary TB, irrespective of HIV status. As a target user, we would want healthcare workers to be able to do this kind of testing. But then as an optimal, we would want a test that is as easy to be done and implemented that a community healthcare worker or a lay caregiver with minimal training can also run this test. That is the idea, the vision for an innovation. And that is how we tried to put together for all these characteristics, each of these in the document. Now, coming to diagnostic accuracy for TPP, as I said, we did certain modeling, but just quickly going through what this modeling really looked at. So most of you would have seen the the care cascade. So there's a person who has TB, but then people who actually have TB should be getting tested to confirm that they have TB. And that is where people fall out of the care cascade, that they don't get tested, and then people are not put on treatment, and there is no follow-up. So that is the usual big care cascade. What we did do, because we were talking about the diagnostic TPP here, we kind of zoomed in on the diagnostic care cascade. So people who have TB, some of them would be given a consultation and they would be asked to get a confirmatory test, post-screening, etc. But there are certain people who are either there is no test, they are unable to produce sputum, or just not, or there is currently no test that exists because of certain traits or characteristics. And then even if somebody gets a test, sometimes it's the sample, they provide a sample, but the sample never reaches the lab, or it is there is an error, or just the test is not happening. And then at the end, the test happens. If some of the people can actually go and reach up until this column, there is a test that is being done. There is a result. However, the result does not have a feedback loop, and the person is just not put on treatment. And these are different steps where we do end up losing people in this care cascade. So yeah, this is just the text. So the L1, the test was not offered when it was indicated, or there was no appropriate test available. The samples just probably don't reach the lab, or the results are not returned back to the clinic. And the third one, that the patient did not receive the result back or was not put on treatment. Now, what are the potential innovations that can help and prevent people from falling and missing from this care cascade? So for each of these, for example, the first one could be if there are more non-sputum based tests, because that is where if somebody is unable to produce a sputum, that person would not be able to get tested. So maybe a non-sputum based test could be helpful. Maybe if there is a test where the person really seeks care and there is no sample workflow that is required, the person can get tested on site, and the results potentially in a perfect world is returned back in the same clinical interaction, and that is where the person can be put on treatment as well. So this is how we tried to solve for this question, which was how do diagnostics with different sensitivity and specificity implemented at different points in the care cascade affect the total number of people that are being put on TB treatment. So this was a guiding question. This was a care cascade. This was what we were trying to look for and answer for. And here are the sample results. So as I said, that there were 3 different countries that we looked at. This is a snapshot from South Africa. So how to read these results? We looked at 2 different prevalences, 10% and 30%. Now, the dotted line is the baseline, the standard of care. So which is how many individuals are actually notified and put on treatment. And the different combinations that we looked at were sputum, non-sputum, but also on-site, off-site, same clinical encounter. What it really means is that off-site would be a low complexity test like expert, An on-site would be a near point of care test. If there's a peripheral PHC setting, that is where the test is happening. And a same clinical encounter is a point of care test right there. And so you will see all these different 6 lines with combinations of sputum, non-sputum in these 3 different settings. Now, if you will see that this turquoise line here, when you see this is expert MTB-RIF. So we all know this is a standard of care and it has a sensitivity of 90%, which is where it is reaching that standard of care, do no harm, people being able to put on treatment. However, a sputum on-site, which is this blue line, which is a near point of care test, a near point of care test as compared to a low complexity, even if we go down to 85%, just because it is more accessible as compared to a low complexity test, we were able to go lower to 85% as compared to 90% sensitivity. For a sputum-based point of care test, for example, if there is a LAM test that can use sputum as a sample, we could go lower to 80% and we would still be able to reach that baseline. Now, for non-sputum, the estimates reaching this threshold was even lower as expected because it is more accessible. People don't really rely just on sputum. There could be other specimens that are more easily accessible, like swabs or urine or breath condensate. That is accessible and the yield is more. That is why we could go lower. So for example, this green line, it was anyway above, which is a non-sputum, same clinical encounter, meaning non-sputum point of care test. It was always above the threshold. So even at a lower sensitivity of 70%, it was much higher. And this was the same thing that we did for 30% prevalence. So this is what the graph looked like, and it is the same table here. We looked at point of care, near point of care, low complexity, India, South Africa, Kenya, and we presented these results and we proposed one because these are too many numbers. All these numbers could not go into the TPP, obviously. So we proposed the minimum that could go into the TPP document. Now, why these estimates are different? Because the standard of care is very different in all these 3 countries. Kenya was primarily relying on smear microscopy as the standard of care for TB diagnostics, or an open PCR TB LAMP test. India was less reliant on expert, but obviously some of the settings were relying on expert or TrueNat, and South Africa was more centralized. So the estimates obviously differed based on the standard of care in each of these 3 countries. Now, all of this was the exercise for presenting to the TPP development group, get feedback from them on what makes sense. But it is not just purely an academic exercise only. It is academic. There are public health experts, but there are also advocates and civil society people who are part of that TPP development group. So even some aspects from the advocacy was taken into consideration, and this was what the final document will have, that a sputum-based low complexity, the baseline as a minimal should be 90%, sputum near point of care 85%, sputum point of care 75%, and then we had a 10% drop in each of these for non-sputum based test. But again, as an optimal, pushing the manufacturers, we wanted them to reach the 95%. Maybe there are more innovations that could reach that 95%. Because it was a diagnostic test, we did expect them to reach that 98% or higher specificity because it was a diagnostic test. For pricing, we did a budget neutralization approach and again looked what would be feasible, realistic, but also pushing the boundaries a little bit. This is what the estimates finally are presented in the published document, where we started off with the $8 as a low complexity, which was export-like test, and then a near point of care getting down to $6, a point of care $4, and obviously as an optimal, it would be less. It was a budget neutralization approach, and the lower prices that are reflected here just basically represents the greater number of tests would be done, probably because it's more accessible, more people could get tested on these near point of care and point of care tests. And then lastly, I'm not going to go into the final text of each of these operational characteristics, but just trying to list out that there were a lot of these sample types, the environmental impact, what is the data privacy, the power requirements, etc., that manufacturers should really look at when they're developing a test as well. Because it's not just how accurate your test is or how cheap your test is. If it's just not implementable on the ground, it's not going to be taken up by countries, and it would just be an instrument or a test lying on the shelf. So these operational characteristics are also really important, and there was a lot of time and effort that went into putting this together. And lastly, I just wanted to acknowledge people who really helped put this together: Nazir, Alexei from the WHO, Brooke and Alex, who really worked very hard getting this modeling piece together. It was funded by the Gates Foundation, the TPP co-writing group, and the development group as well. And thank you for your attention, and happy to take questions.
Thank you so much, Prof, for your presentation. I see a round of applause from our attendees. Thank you so much. If you have a question or comment for Prof today, please do raise your hand and unmute yourself. Thanks for the round of applause. Okay, Mark, you may go ahead.
Thanks. Thanks for a great presentation. I appreciate you've focused on the diagnostic use case, but one slide that you showed in the beginning caught my attention, and that was the definition of a screening test, which looked very much like what we previously called a triage test for people with presumed TB who present for care. So could you unpack a little bit for us whether in fact that terminology has changed, and if it has changed, what do we now call what used to be a screening test for differentiation of TB in the community among people not thought to have TB?
Yeah, that's a great point. So this is what we started off with screening, and as I mentioned, I wanted to hone in on one specific TPP. Maybe we could have another webinar on the screening TPP. So the screening TPP, we did go down to people. So I think what you're asking is with symptoms presumed to have TB, but also on high-risk population, like people living with HIV or diabetes, and different prevalences. So this time, we did not look at a specific screening and a triage TPP, but we tried to unpack both of these symptoms, asymptomatic, high-risk groups, lower prevalences, probably asymptomatic people who still have TB should get tested as well because of risk factors. We did look at that in the screening TPP, and we try and unpack that in that document. Yeah.
Okay, thanks. I think I understand.
Thank you so much, Mark. Any other question or comment? Tom, you may go ahead.
Hi, Mikashmi. A couple of questions, really. One is, was there any debate about using the term sensitivity and specificity to define these tests? I think they're highly misunderstood terms and overvalued. So if I wasn't involved in this, if I was involved, I would have said these are the wrong terms to be using. And a second point is about TB spectrum, which is something which is increasingly being recognized. You talk about TB and latent TB, but of course we have large numbers of people who have neither, but have an intermediate level of disease. So did you consider how tests might actually be looking for something which is on the spectrum of disease. Thanks.
Thanks, Tom. So first one on the sensitivity specificity. I think if the idea is to look at something else like a PPV, NPV, was that what? So, I mean, maybe I would just want to understand if there was a different proposal that you might have than using.
Well, yeah, there are lots of possibilities. I mean, what we're really interested in is whether these tests improve outcomes. And we know that LAM improves outcome, and we know that EXPERT doesn't improve outcome from the studies that were done. And that's a long discussion in itself, but the randomized controlled trials of EXPERT all showed no effect. However, I still think that I still have confidence in that test, and I think it's because the studies were poorly designed. But if this was a drug, we would be saying you have to show efficacy, not diagnostic accuracy. So, and ultimately, if someone's asking me to make a public health decision about introducing a new test, I want to see that it improves patient outcomes. So I just wonder, I mean, you could also use likelihood ratios or predictive values, but that is the test of a test, whether it improves outcomes, not whether it's got a sensitivity or specificity. That was my point.
Good, thank you. So thanks for explaining that. So there was a lot of discussion around it. The reason that we have historically, and also this time in the update, we did not use these people-centric outcomes or people-important outcome is because these documents, as I mentioned, they are more manufacturer-facing. Now, implementing a test could do really well, but not implemented in an optimal manner could also lead to different outcomes. But I think because the use case of this TPP is more from the technology perspective and more on whether the test really works or not, and then further down the line is more of an operational manual, more of an implementation manual, where we look at people-centric outcomes. And those are two different documents, as you would see in the WHO. So I think from the perspective of a TPP, I think the idea was in the group that we stick with what manufacturers really have control over, which is how to design a test and how to make it functional, and to really correctly diagnose, rule in or rule out people. So that is the space that manufacturers really have control over. However, people-centric outcomes, they come more in when we are generating evidence around that test, and how it is implemented and accepted in the community. So I think we were trying to differentiate between the two, and that was the discussion that we had in these as well. And the reason, and the last point that I do want to add is because when manufacturers look at this document, they go back, they do studies to see, have I reached this outcome or not? And then doing an RCT from the manufacturer perspective would be a little hard. So that is the responsibility that relies more on us, on the TB community, to actually see if it has any public health impact or not. But I completely agree with your point that it's not just the accuracy that really matters; it's all the other aspects that you mentioned. But yeah, this is one limitation of the document for sure. So I'm not sure if I could answer that question, but
yes,
this
you
is
did. Thank you.
the discussion.
Yeah.
Okay. And the other
second
one,
point, yeah.
The other point on the spectrum. So yes, for the spectrum, and I think early next year we will see the screening TPP coming out, because you're absolutely right. We just had a meeting at the WHO 3 weeks ago on looking exactly at that spectrum. So as you said, it could be people having symptoms but not having that disease. It is latent TB infection, but then there are also people who are asymptomatic but have confirmatory TB. So lying across that spectrum. In the screening, we try to kind of cover those pieces in some form. But again, there are different stages within the spectrum that are still missing in these two TPPs. There was a proposal to come up with a screening, a diagnostic TPP, and one level above, which is a subclinical TB TPP. There was this other proposal that we were trying to to work around. But because we don't really have a consensus, we didn't have a consensus definition of subclinical TB up until now, we could not really develop that. But I think as along the way, we are figuring that out, like now in the 2024 WHO report, the first time mentioned the asymptomatic confirmed TB cases. I think more work still needs to be done in defining and diagnosing these different stages within the spectrum. But once we have more clarity on consensus on how do we look through these different stages, we probably will have to define and update these documents again. But currently, we try to capture that in some form in the screening TPP, but nothing in the diagnostic.
Thank you.
Before we give you back 10 minutes of your time, are there any other questions or comments from our attendees today? Please do raise your hand and unmute. Perhaps does our speaker have any closing remarks that they'd like to share with us before we do end our session a bit early today, Prof?
No, I think it was super interesting. It was good to answer some of the questions if I could. And yeah, it was interesting. Happy to answer any questions if there are. I think my email address is there if there are more questions. And I could also ping you all on the email chain that I have when the screening TPP comes out. So if you have further questions, happy to answer them offline as well.
Thank you so much, Prof. We'll keep in touch with you regarding the screening TPP early next year. Perhaps we'll have a session on that as well. And if you have, this is for the attendees, if you have a question that may come up throughout the day, you are free to email us at the Secretariat. And of course, if you'd like to see yourself on this very platform in the upcoming months, please do email myself at ngosi@tbthinktank.org or anyone else within the Secretariat. And with that said, colleagues, I'd like to thank our presenter, Prof. Thank you so much for your time and your presentation. And thanks to those in attendance today. And enjoy the rest of your day. Thank you so much.
Thanks, everyone.
Bye.
Thank you, Kwazi, and bye.
Bye.